I'm good to go. Oh, good. We're even recording. Excellent. So I am here with my colleagues, Reka Stopla, and she is the regional director, and she's just going to share, hopefully you can see, she's going to share her screen there. Reka Stopa, sorry. I said that name probably 15 times in my life at least, is the regional director of West Africa and Sahel region with Concern. So we are your facilitators today. And we're going to have presenters by Asatu. We're going to have presentations. Sorry.
No, because she's making the presentation.
You can just tell me now, Jillian.
Is she? Oh, good.
Jillian, we can hear you. If you want to tell me something, go ahead. Okay. So the presentations by Asatu Dullah from ERNE program the ERNE program manager in Concern South Sudan, and then we'll have a presentation by Ayalna Shmegra in our health and nutrition, sorry, that should say coordinator in Concern Ethiopia. And I think we can move to the next slide. There we go. So we have the objective, as you just heard in that last session, is to agree 1 to 2 recommendations. We'll see how we get on with 1, and some key considerations on improving access to health and nutrition services when populations are displaced or static facilities are compromised or inaccessible during conflict. And I should stop here to say, to apologize to our Francophone colleagues, but the simultaneous translation will not come into the Zoom breakout room, unfortunately. That is just a problem with Zoom, but we also have my colleague Christine Kiernan here, who is our note taker for the session, and she has kindly put the French translation below the English there. So the agenda, very quickly, is that we will spend about 10 minutes on this and some key points. We will then move to the South Sudan presentation, 10 minutes, the Ethiopia presentation, and then we'll have some Q&A about the South Sudan and Ethiopia experience. And then we'll move into our discussion and agree key recommendations for about 35 to 40 minutes. Next slide, please. Did I just keep talking? Yeah. Okay, so the key points that we wanted to just frame this discussion around access. So access includes different components. So it's availability in the first place of the service, having geographic access, so making sure that available service is near enough to people so that they can reach it. The affordability, we know even in places where fees for consultations or medicines appear to be free, for example, for under 5s, that there is always some level of cost to families. And then the acceptability of the service as well. The challenges outlined in the previous session determine whether the service is available, where and when, and of what quality. So we realize that there are lots of different components that interact with access. But for this session, we probably really want to focus in on geographic access and how mobile services can improve that. So in conflict and acute periods of displacement, these shocks and stresses can have a dramatic impact on health service access, and the communities in all 5 ERNE program areas experience both, but particularly in South Sudan and Ethiopia in 2022. In South Sudan, communities experienced mass displacement resulting from unprecedented floods, which you'll hear about in a moment. Next slide, please. And in Ethiopia, as we've mentioned several times, active conflict in Tigray forced tens of thousands of people to leave their homes, and many moving rapidly into the ERNE program area. Concerned program teams in both contexts have coordinated closely with the Ministry of Health and shifted to delivering mobile health and nutrition services. And such mobile services provide a lifeline, we know, for people who have been displaced away from static facilities. But we also know that mobile health teams and approaches are costly, largely unsustainable, and may actually detract from efforts to improve access and quality of health services over the longer term. So with that, we will launch into Asatu's presentation. Asatu, welcome, and over to you.
Thank you very much, Kate. Good morning, everyone. Please allow me to switch off my camera as we have very weak internet connectivity. Thank you. In South Sudan, you can proceed to the next slide. In South Sudan, we have, as you might know, South Sudan is very prone and susceptible to flooding because of the topography. It is a very flat and plain land. And there are a number of issues from the neighboring countries, the heavy rain contributing to the flood, as well as it is along the basin of River Nile. And in 2019, in 2022, 21, starting from 2020, there was a massive flooding happened in the area, overall in the country. Above 800 people were displaced, and specifically in the location where we are implementing this program, 90% of the location was flooded, and it caused the displacement of 120 people within the target location. And this target location, we have 3 health facilities and 3 outreach services for nutrition attached to this facility. So from this picture, you can see how the unprecedented massive flood affected one of the facility here. And you can see until that facility was fully submerged, services were going on. And when it gets submerged, we had to move and relocate, provide services. In South Sudan, this is the map. It is located in the eastern part of Africa, and the place where we are implementing this northern location. And you can see from the map, these black colored arrows, they show the first round displacement, and the red arrows show the second round displacement. And there were also the third, and some community members were displaced for 4 times, moving from one location to the other. And one of our facility was completely submerged, and around 40,000 people were forced to move and settle in neighboring locations. Next slide. We had to create some coordination and a synergy between different humanitarian actors as well as community members and UN agencies and the government counterparts in order to mitigate the situation that we have been facing. We did a rapid assessment, and we followed where community members were moved and settled. And we had to organize and collaborate with the different stakeholders to establish services in the locations where community members were moved and settled on the few higher grounds available in that different locations. So with the government and especially WHO and the UNICEF, they provided some high performance tents, as you can see from the picture, so that when we had complete submersion of our facility, we had to erect those high performance tents from WHO and UNICEF immediately and ensured continuity of the services. And the community members in the middle of the crisis, as you can see from the picture, they managed to try to protect further damage, and they contributed their skill and their labor to protect flood and for future disaster in the same manner. So they tried their best to organize themselves. And we had also a strong collaboration with the community members in constructing dikes and changing the course of the water. Next slide. So because of this heavy rain and the area by itself is flat, as I mentioned, and it is very wet area, there is complete devastation of infrastructure, no road accessibility. Our vehicles were grounded because we had nowhere to use our vehicles. So we had to quickly, flexibly use canoes and motorized boats to transport drugs, nutrition supplies, and preposition some of the nutritional supplies. And even for monitoring activities to the field, we had to use these facilities. And it used to take 2 days, which otherwise during the normal period of time, 2 hours drive, it had taken 2 days to reach to those facilities and to reach people who have been settled in islands, in a very isolated and far locations. And in the same model, we tried to modify and develop operational strategy to scale up and address the needs of displaced people with multi-purpose cash assistance. And we moved to different locations and established health and nutrition facility, which is closer to the border of Republic of Sudan. And we had to bring that and a scaling up of response so that community members receive their health services, nutrition services, plus to address their basic needs. We had to provide multi-purpose cash assistance in those locations, as you can see from the picture. And the impact is too much, as you can see from that picture. The background is completely affect the ecosystem because of the 2 years suffocation of water. It just killed all the trees, and the trees are now dried up, and the ecosystem is completely changed. And the future of that location is also at serious stake. Next slide. Next, okay. Some lessons we learned is the collaboration with the county health department, CHD, community members, humanitarian partners, including the ECHO, that allowed for continuity of the critical services. And the collaboration with the community members, we used the canoes and motorized boats only based on the level of water. When the level of water is very shallow, we had to mobilize community members and community volunteers so that they should carry, as pictured it here, those people, they had to carry nutrition supplies more than 3 to 4 kilometers to reach the places where community members are settled. And operationally, we saw flexibility and adaptable use of whatever available means for transportation, like canoes and the motorboat. The other very important issue that we learned, and that should be maximized for future, is the village level disaster management committee and the community members demonstrated their capacity to provide labor to protect the health and nutrition facility from similar disasters. So that is a big lesson that we learned. Next slide. We have a recommendation here from the right side. You can see the very substandard kind of canoe that we use to transport supplies and drugs to health and nutrition facility where the community members were settled. And some of the critical recommendation we forward is there is a need for coordinated mobile health and nutrition strategy for a context like Unity, because we have been using the government incentivized health workers to provide health service in that specific location. There is a need for a stronger preparedness planning, early warning, and early action at locations including identifying locations where community members should settle in the event of such a disaster. And prepositioning supplies, storage facilities is very important. We have ongoing collaboration with some humanitarian organizations who have the WFP provided those big wrappers where we preposition supplies and some items. And building the community resilient through awareness campaign, training, and education on flood safety and preparedness is one of the critical areas that we recommend. Contingency planning involving all stakeholders, government and community members, including humanitarian actors, is very important. And fostering cross-sectoral collaboration and a partnership among stakeholders, that is one of the critical area we have observed, because there are a number of complementarity issues we observed and utilize the opportunity to address the needs of community. And the future donors to consider crisis modifier for dynamic contexts like South Sudan, as ECHO has used for the recent heat. The inclusion of crisis modifier is one of the instrumental tool to address the basic needs of community members during the disaster of a similar scale. Next slide. This is what I have for you. Thank you very much for your time.
Thank you so much, Asatu. Fantastic presentation, really giving us some of the nuts and bolts and dirt and water and wetness that we all have dug into at different times. So now, Ayalnish, I'm going to hand over to you. I'd like to introduce Ayalnish Megra, our Health and Nutrition Coordinator in Ethiopia, who's going to talk about mobile health and nutrition teams in Ethiopia. Over to you, Ayal.
Hello, everyone. Thank you, Kate, for giving me the chance. So I will be taking you through the mobile health and nutrition team approach in Ethiopia. Next slide, please. So my presentation outline includes the background of mobile health and nutrition in Ethiopia, concerns experience, the learnings from these mobile teams, the way forward and recommendations. So to start to be the background of MHNT, this mobile health and nutrition team started in Ethiopia in Somali region in 2014 by the government, which is the Federal Ministry of Health, to meet the hard-to-reach population in there. And following that, international NGOs started deploying MHNTs with a similar approach of operation, but with specific project-defined variations. And in recent years, MHNTs have been scaled up to improve access for drought-affected pastoralist communities and those impacted by conflict in many regions of the country. Currently, we are implementing it in around 7 regions, including Tigray and Amhara, where concern is operational. And as of April 2023, the government and partners are supporting these MHNTs in 104 waredas of Amhara, where 41 of them are in Amhara and 60 of them are in Tigray. Next, please. So as per the standard of Ethiopian MHNT guideline, the content of MHNT looks like this. It should deliver all the promotive, preventive, and curative and rehabilitative services that are in line with the Ethiopian Essential Health Service Package developed in 2019. And regarding the staffing, at least it should have a physician, health officer, or BSc nurse, clinical nurses, midwife, social mobilizers, and driver. And the budget should be taken into consideration by the Ministry of Health at the national level, the regional health bureaus, and the partners, including Woreda administration. So the referral system is for the cases that are beyond the mobile health and nutrition team, will be referred to the nearest health center or hospital, and the team will facilitate the referral. So they are given free of charge, and their location should be in hard to reach, or if there are any internally displaced people in the areas, or where there are no health facilities or health workers in the health facilities. Next, please. So there was an assessment that was conducted by Ministry of Health and UNICEF in Amhara and Somali region that looks into the trends of MHNT, and it has found out some achievements as well as challenges related to this MHNT implementation. And some of the achievements are increased access to services for the population that are unreached and under-reserved in these areas, and also responding to the health emergencies, including COVID-19, climate shocks, severe and recurrent outbreaks, and conflict-affected areas that has resulted in IDPs. And it has also resulted in increasing capacity of the health extension workers through provision of on-the-job training, as well as through consultation of this mobile health and nutrition team by the health extension workers in cases where they are beyond their capacity. And some of the challenges that were identified by the assessment were the functionality of the MHNTs was highly dependent on external funding that created donor fatigue and poor sustainability. And there was gap in service integration within and across sectors, including the WASH, the nutrition, the health, and the others. And there was also inadequate staffing, like there was a gap in the professional mix of the MHNTs, meaning they might not have all the staff that are supposed to be in the MHNT as per the guideline. And there was also a frequent turnover of the staff. There was also service interruptions due to lack of vehicle spare part, the vehicle itself, funding interruptions and shortage, and inadequate supplies, including drugs, nutrition supplies, and others. There was also inadequate mentoring and supervision as per the finding, and movement restrictions due to security concern and conflict prone areas. Next, please. So when we come to concerns experience in MHNT, concern started implementing MHNT in Tigray in 2021 following the conflict, and it has implemented in 4 waredas of Tigray with the fund that was obtained from BHA, which was followed by 1 wereda in 2022 of Amhara. So these MHNTs supported to provide essential health and nutrition services, including maternal health, like ANC, PNC, family planning, EPI, under 5 consultation, and others that are in line with the guideline. And also concern both buffer stock of drugs to supplement those that are provided by WHO, which we call them emergency health kits. And training was also provided to health workers and health extension workers on like IMNCI, IYCF, CMAM, gender, and the others. Concern followed 2 modalities of staffing for the mobile health and nutrition team in Tigray, one of which is hiring new MHNT staff as per the national guideline, which was funded by BHA. And the other modality was paying incentive to the government staff to continue working in their health centers, which was funded by UNICEF. And the purpose was to retain this staff because they were out of salary for some extended period of time due to the conflicts, and thereby provide health service for the community affected by the conflict. Next slide, please. So the learnings that we took from this, from implementing MHNTs that are important are, we found MHNTs as an important strategy to address acute breaks in access to services at health centers and health posts, especially during the conflict and the displacement. And it has also decreased the travel and waiting time on the communities that are being served by the MHNT and the associated cost for the highly vulnerable communities. And it has improved community mobilization and sensitization because one of the members of, or one of the staff of the maternity are outreach workers or social mobilizers. They go to the community and mobilize the community to let them know that services are provided by the mobile health institution. They create awareness on the community related to health, nutrition, and WASH. So this has also improved in these maternities. And they were highly valued by the World Health Office and the community members, particularly those who benefited from the consultations, be it in adult and under 5. Next, please. So as part of the learning, there are challenges that we have learned, like as per the national guidelines, there are some criteria to be followed to quit or to stop these maternity, like the static health facility service is restored to replace maternity, and an alternative service provision modality should be introduced, like having clinics or health posters in that conflict affected areas or any other service modality. However, ensuring this criteria met as per the guideline was found to be challenging because as an implementing partner, we are dependent on the donor funding, and projects have their lifetime, so it will expire based on the agreed lifetime in funding. Next, please. So on the way forward, especially in the Amhara regions, damaged health facilities are starting to provide the basic health service to the community. So we are working on a gradual scale down plan with the World Health Office. Like they are informed about the scale down of the maternity, and we have also planned to have a closing workshop and handover of the maternity resources to the health office as per the donor procedure is also planned. We have also provided some of the drugs and some medical devices that were part of the kits that we have received from WHO, where we are not using them in the maternity. And the other is, if there is any new opportunity to run a maternity in these areas, this staff, the existing staff, will be used to run the new maternity, or we can also hire new staff, and the materials that are used by the current maternity will be used by the next. This is to show you that there is a rapid reactivation being ready for the next step. Next slide. So regarding the recommendations, there should be, we need to develop a clear strategy to scale down emergencies once the acute emergency has passed. Among the strategies can be better joint planning and monitoring from the start. As we implement every project, we will start the kickoff project with the Ministry of Health and other implementing partners, and more specific and realistic criteria on when and how to begin scale down should be there based on our experience, and activities for the transition phase until the services are back to the pre-conflict or pre-damage state should be there. And there should be also a clear communication to service users, as this is not a permanent or this is not a continuation until it is being providing service for the time being. And the other is efforts and coordinated funding to restore and strengthen services at static health centers and health posters must be made alongside maternity. This was also raised by the regional government, the Warada Health Office in the like, to have support on strengthening the existing health system rather than continuing on emergencies, as emergencies are not sustainable solutions. Next slide. So this is a picture that shows under 5 consultation in the shade of the maternity. Next. So this is the health extension workers with concerned staff sorting cards for the SFP beneficiary in one of the qabalis. Next. So this is health education being given in the shade of the MHNT. Next. This is also about health education in the other qabalis. Next. So this is to show how the shade is being established and the people waiting outside the shade. Next. So this is the cooking demonstration session conducted at the MHNT site. The left side is showing how to prepare, and then the right side picture is how the children are eating the enriched porridge that was prepared in the MHNT site. Next. This is all I have. Thank you so much.
That is great, and that's setting us, thanks Ayalnish, that is great and setting us up for our discussion. But I'm going to pause there to see if anybody has any specific questions they want to ask Asatu or Ayalnish. But also, can I ask that everybody puts their cameras on? We can start to get to know each other a little bit. And I think we still have a few lurking Gillian McCarthy's. So if everybody puts their camera on, we might just address that so we know everybody's name. Richard has his. Oh, and I see Richard has his hand up already. So Jackie, I see you've got your camera on. I think is yours on. Oh, let's see what we all look like. Can you all see me? I see Jackie, I see Reka. Christine. If you really don't want to put it on, you're in the middle of something or have a sick child at home, I completely understand. But okay. Maybe we'll just launch into questions then, and starting with Richard. Did you have a question for Ayalnish or Asatu?
Yeah, thanks, Kate. It's a question for both. Great presentations. Thank you for that. I just wanted to know from perhaps a mobile service delivery viewpoint, if we're looking at displacement to host communities, usually host communities in the vicinity will have a health post or a health center, maybe not too far away. My experience of these health posts that I've seen, they have very inadequate wash capacity. I just wondered whether the wash element was considered in the mobile strategy and whether you had any thoughts on how that could be handled within a context of severe displacement. That's for either Isatu or, sorry, the presenter from Ethiopia.
Ayalnish, do you want to take that one? How do you manage WASH in these mobile health and nutrition teams? Since you're out in the middle of nowhere often. You with us, Ayalnish? I see you. They can't hear you.
Kate.
There we are. Did you hear that question?
Yes, I think how do you manage the wash component in the emergencies?
How do you have enough water and sanitation?
Yeah, actually we were not doing the hardware part of the wash activity, but we were providing information about personal hygiene and environmental hygiene, how they can keep their like distribution of water treatment chemicals by other organizations and the like. So we were telling them how to use that and how to use the available resources related to wash and how to keep animal and children, including children, feces away, and how to wash their hands by demonstrating the hand washing techniques and the like. So we were emphasizing on the software aspect because we were not having wash hardware structure in these specific projects. If I go to your question, well.
Can I add, Kate, something?
Yeah, please. Is that Lo Saged?
Yes,
From our
thank you so much.
Ethiopia team, please do.
Yeah, thank you so much. Thank you also for organizing such, great event so that everyone can learn from the different country programs we have through this ERNE engagement. So, I mean, we also avail hand washing facility in the makeshift clinics that we are operational. Like whenever we set up mobile health and nutrition clinics, we also have hand washing facilities, and we use different types of PCC materials that we already developed for wash interventions. And also, as Ayar said, we also support government and other NGOs to set up wash facilities, especially in the camps. Just providing information about hygiene, promotion, sanitation is not enough as long as you are not providing the input is not there. So we usually encourage partners to set up hand washing and toilet latrine facilities in IDP settings, and also review our work during sub-cluster meetings that we have in the regions. Over. Thank you.
Thanks, Lo. Basatu, do you want to share how you managed to have clean water and sanitation at the mobile service sites in South Sudan?
Thank you for the question. In our context, it was very difficult because only 10% of the total catchment area was remained as dry ground, as a higher ground. So establishing water system in those locations was really very difficult. But we tried our best to coordinate with the UNICEF and with the CORD-AID whenever they have additional this water treatment chemicals. And from our side, we tried our best to pass awareness creation message on personal hygiene and sanitation. So in the context of like South Sudan, everyone was affected, and the wash component, it requires some special kind of treatment and the setting up facility and uninterrupted provision of services. So from our side, we also learned something very strong from that side, and we learned that we could have done something more stronger, equivalent to the continuity of services on health, nutrition, and the cash transfer. The wash component should have been done to that level, but the nature and the contextual situation of our context didn't to reach to that level. And our best in transporting and coordinating with CORD-AID and the UNICEF and the WHO during the treatment with chemicals and items transporting using our canoes and motorized boats. Thank you.
Thanks, Asatu.
Hey,
Please.
I have a quick follow-up question to this.
Sure, go ahead.
Yeah, I was just wondering because for Ethiopia, the emphasis they said was on software. Was that deliberate, or was that more because you couldn't get the funding to either rehabilitate or look into alternative water supply strategies in a mobile context? Were there challenges beyond your control in that respect, or was that just something that didn't seem to be an immediate need? And how would you think about trying to build either more protection strategies to wash provision within future programs, and maybe contingency planning? Would that be an idea for health centers to strengthen their wash capability during emergencies? Just wanted to get a little bit more insight on that, if that's possible.
Ayanish, do you want to take that? I mean, I can also speak, having been with Ayanish in the Somali region, that in the drought situation in the Somali region, there is no water. And so concern was engaged in water trucking. We developed roof water harvesting, rainwater harvesting in the roof and tanks. And where it was possible and there was a community source, we did support piping from the community source into the health facility. So all means were tried. But during that dry season, I mean, the community and the health facility is facing exactly the same barriers. There is no water. So water trucking was really all they could do for about 6 months. So in terms of contingency stocks of water, I think we're going to have to probably improve some technology around rainwater harvesting up to the point in the dry season where you can still keep reservoirs. But I'll just say that I was really struck that there's only so much you can do in those locations. And then you're basically stealing from Peter to pay Paul. You're taking water from, far away, a river, so that you can get it to the health facilities. But Ayanish, is there anything else you want to add? I mean, were you water trucking to the mobile health and nutrition team sites, for example? And is there any way that you could in the future help health facilities maybe do some contingency planning?
No, we were not providing this activity or this service in our MHNT activities because MHNTs are providing very short period of time support, and the WASH activities, they do need a huge amount of budget and time to develop during development of the proposal. So we can take this forward for the coming for our future proposal development. Otherwise, it will be it is good to have WASH activities, because in the absence of WASH activities, it might be difficult to implement health and nutrition activities. But in our current activities, we didn't include this WASH. I don't have any additional rather than kids side. If Musagad have anything to add, that's it.
Thanks, Ayanish. I might just move us along. I realize the clock is ticking. And Ruth Situma from South Sudan, our nutrition cluster coordinator, I believe, in South Sudan. Do you want to come in?
Yes, thank you. Thank you so much, Kate. And thanks, Ayanish and Satu, for very, very interesting presentations, as well as really lots of good learnings that can be brought to scale. I have a couple of questions, just in terms of with displacements, we often see also increase in gender-based violence, and just wondering, at least for South Sudan, I know that's a big concern for us. Just wondering whether this was also integrated as part of the mobile health and nutrition services, and how did it work in terms of the linkages? That's number one. And then secondly, I saw Esatu mentioned about working with the disaster management committees, and I know that we have mother-to-mother support groups, we have community nutrition volunteers, we have boomer health workers. Just wondering how that the different community systems and structures that we have in place, how they worked out in response, and how we can do better in terms of harmonizing this. And then finally, I see that you also used the multi-purpose cache, if I'm not wrong, from your presentation, SR2. Just wondering how we ensured, for example, the market functionality, given with the floods, because I know when we have floods, then also the, some of the access issues, access becomes a big issue. So just wondering how that was ensured, and if we also looked at what that cache was used for. So thank you so much, and back to you, Kate.
And straight over to you, Asatu.
Okay,
those
thank you.
three.
Thank you for the question from South Sudan. Let me start from the last one. That is true. During that massive flooding, the access to market and the market functionality was a serious concern in that location, especially Unity State. And in any way, in Rukona and Bentiu towns, including Roriak, the markets were functional. But how those community members displaced in far locations tried to access markets and the supplies from Bentiu Rukona. So we had to, because it is very expensive, as you might know, it is very expensive to use canoes or motorized boats from far locations to come to Bentiu and Rukona. So we had to organize and mobilize community members in a group. So the group representative for 10 or 15 households, they selected a representative or person to use a canoe and to travel to where the markets are available and buy supplies from those markets and return back to the localities like, if you know, Kwach and Chotiel, Dorbo areas. So that was the only means they had to use to get supplies for the market by using canoes. And there were some locally available markets in the rural towns, but during the disaster, they were completely non-functional and not accessible. So that was the way that we managed to reach those people at far distance. The community, the disaster management committee at grassroots level as a part of the early warning, early action. These are the DRR committee we established, and they were provided with appropriate training for preparedness and monitoring community level risk and providing those information. And they were also mandated to mobilize the community members in order to make some structures how to protect the facilities from future disaster. And in addition to, there are a number of mother to mother, father to father, and a number of groups, even health management committee. So as it is clear in most of these committee members, they participate in one or the other. So we just preferred to use the disaster management committee as leading, because this group of people, the father to father, mother to mother group, they continued the service delivery and their meetings, regular meetings, and passing nutrition-related awareness creation message to the affected population. But when it comes to preparedness and constructing structures for future disaster prevention, we managed to use this disaster management committee. For GBV, we coordinate with the protection humanitarian organizations. The DRC, we had a strong collaboration with DRC because the concern doesn't have, especially with GBV related activities, we have very special IRC and the DRC been there. So we coordinate because they have sites and locations and activities. So we work together, and whenever there was those kinds of reports related with that, they were the one managing and handling GBV related things. So we have to give that space to specialized organizations. Yeah, thank you.
Thanks, Asatu. We have 3 questions in the queue here, and we don't want to stop this, but if we could just be thinking, maybe moving a little bit more towards the mobile health and nutrition teams and their sustainability and the way forward in your questioning. So I'm going to go to Amal Tucker-Brown. Amal, do you want to introduce yourself and ask your question? One question, please.
Well, hi, yes, my name is Amal Tucker-Brown. I'm a consultant. I'm currently looking specifically at the surge model and rapid response mechanisms in Ethiopia. So a little bit documenting this. So this workshop is coming at the perfect time. I have one quick question. My internet's not very good, so I may have missed it during the presentations. But where I didn't really see clearly is, when do you decide to move the mobile health and nutrition teams? And what are some, and if you have moved them, if you've been successful in moving them out, what have been some of the challenges? I know both contexts very well, and I know that the mobile health and nutrition team that were established in 2015 in Afar are still going on in Afar. So it's questions really about how to move them out. And apologies if that was answered, but thank you.
Okay, I'm going to hand that to Ayanish, where I think the mobile health and nutrition team strategy is at least out there from the Ministry of Health, but I think a lot of those challenges of deciding when to move, when to activate and move them and then scale them down are some of the questions that we want to grapple with. So over to you, Ayal, for a brief response, but I think that's going to move us nicely into the issue at hand and getting closer to a recommendation around this issue. So over to you, Ayal.
There are some criteria that are put in the National MHNT guideline. In the MHNT guideline that says when the existing health service is back into giving the necessary support, and if there are any other modalities to cover the hard to reach or the displaced people in that specific area. But related to our case, as it is, don't know, budget and the timeline bounded implementation, we will be getting out of an implementation area when the lifetime has stopped. But we at the same time strengthen the existing health services while implementing the MHNT activities, meaning we provide technical training to the staff, we provide some materials to the existing health system, including the medications for the existing health system. So even though it is difficult to be in line with the standard, but at least we will wait until the existing static health facilities started to provide the basic health services. Thank you.
Thanks, Ayal. I think maybe we can move into that section of our discussion, and Reka, I think, who's sitting right next to me, but you wouldn't know it from looking at the screen, is going to share her screen. So we can look at a recommendation, a very broad recommendation that we have, that I shared in the previous presentation around this. And what we'd really like to start noting underneath is, and some key considerations for feedback to the group based on your experience, is how can we take this recommendation forward, and how can we better articulate some scale up and scale down strategies for mobile health and nutrition teams. And Suzanne, thanks. I saw your note in the chat that you had a similar question to Amal's. So Reka is sharing her screen, and you can see that recommendation at the top. And by the way, it doesn't look like we have any real Francophones. I hope everyone is following the conversation, or maybe you are Francophones, but you're also able to follow in English. But if you do have a question in French, I'm sitting next to two very fluent Francophones here. So don't be shy, and you can put your question in the chat or raise your hand and ask in French. So I think so I'm going to read out the recommendation here. You can see it on your screen. So as I said, it's quite broad, and it's reflecting experience in South Sudan and Ethiopia, that organizations, ministries of health working in such contexts should plan for mobile services in contexts where displacement is likely, or static facilities may be damaged or inaccessible due to conflict, but have a clear strategy on when and where mobile services should be activated and scaled down, the standard package of services and staffing, and the budget required. So I think that is drawn from both presentations. And now we'd like to hear from you, anyone who has experience on this with has anyone else on the call had experience with mobile health and nutrition teams that you'd like to quickly share and to offer some key considerations that we could put to underneath this recommendation to take it forward? Yes, Amal, please.
Yes, sorry. Yes, having done mobile health nutrition teams in both South Sudan and in Ethiopia, I think one of the elements, I mean, realistically, in most areas where there is displacement is often, not always, but often in areas where the health system is already extremely weak, or there is lack of services already. Somali region, Afar, a lot of parts of South Sudan. And so the idea of being able to hand over to a health service when you're scaling down is a laudable idea, but in most cases, the service was already poor to start with. And then you have a situation where you have an influx of population, probably of different ethnic groups. And then you have a high quality, very high quality. I've seen concerns, mobile health and nutrition teams, very high quality of service provided. And that is then scaled down, and then you're got back to a very basic service. So again, even the local population has tasted something good and better, and back to basics. So I'm just wondering, in any context, has health systems considered utilizing mobile health and nutrition team as part of their health system that can be utilized? I don't know if that question's clear.
Thanks, Amal. That's very clear. And it's one of the questions we actually also thought about. You know, one of the things we're looking at is a lot of health systems have what's called extension services or outreach services or service for ERNE, where from the health facility every several weeks or once a month, the health facility staff must go out to certain areas and certain sites. And so we've been looking a little bit at having a discussion today about what are the differences between that and what we're calling here a mobile health and nutrition team or mobile health services. And if anybody else in the chat has thoughts about Amal's two great points about, you know, the high quality that's provided at these in the mobile services, and how do we then scale down and transition back, especially if the health facility services are not strong. Does anyone have some thoughts or recommendations to share on that? And I wonder, would it be better if I stop sharing the screen so we can see each other when we speak, or? I think it's not right. I'll stop sharing the screen. It might be nicer that we could see each other. Anybody have thoughts on Amal's point? Jackie, please.
Yes, I'll come in here with a thought. I think with the mobile clinics, as you say, if you're delivering better quality service and you can't keep that up because there is an extra cost. If we look at the flip side, your mobile health service might be an awareness raising tool to get people who normally wouldn't travel to the health service just to consider that. So I think we just always have to look at both two sides, you know, the two sides of the coin, you know, the improved coverage, improved quality. But in the end, we know that getting people to move to the health services is our day-to-day job. So maybe just try to look at it that way.
Okay, so using kind of the mobile health teams as the referral service and really encouraging people to go to that service. Regina, over to you.
Yeah, my understanding was always that the mobile clinics will be activated as part of the search model when the static sites are overwhelmed. So then to have additional health workers going out to sites where there are a lot of people asking for health services, so that then you take away some caseload of like some people who would normally come to the health facility, but because the health facility is overwhelmed, you treat people where they are coming from, like the hotspots. And with that, the moment you see caseloads going down, you would scale down your mobile activities again, or relocate them to locations where you see then more patients coming from. So you would not set up really, like I saw from the pictures, like shelter. It's more about going to those sites depending on the needs, and not maybe creating so much expectation that this will remain a health facility forever, but to have more the nature of it's mobile. It responds to increased needs for a short time, and then is relocated to another location where there are unmet needs, or where we see majority of people coming from walking long distances, and just to fill that gap for a very short period. But I can see from the pictures that, yes, the increase in needs is probably more permanent than what the normal search model would be able to handle. I don't have an answer to that.
Thanks, Regina. I think you raised some interesting points there about, first of all, not kind of creating expectation about where these mobile health teams will be, and creating expectation of permanence, but moving at where the caseloads are. But I think at the beginning, you also raised an interesting point about, do we use the same staff who are in the static health facilities, or are you actually using additional Ministry of Health staff, or are you using additional, is it NGO staff, or how are you dealing with that to not drain the resources from the health facilities themselves? I don't know if Suzanne is next. I don't know if you have an answer to that, or a separate question, but please come in, Suzanne.
I hope you can hear me.
Yes.
Sorry, I just wanted to add my thoughts to the sentiment as well. For me, I think for me, it takes us back to the drawing board. One commonality between the Ethiopia and South Sudan presentation is that they were both targeting areas with very weak health systems and areas that are really already underserved in terms of health system. So when it comes to how do you scale up and how do you scale down, or how do you activate, that's already an area that is already, we're starting from a very weak vantage point, because these are areas like, the Somali region has been underserved for the longest time. And South Sudan also, the health system is very weak, and the Ministry of Health is not even capable to support the health system at the moment in the government. So it makes you question that, okay, if you want to hand over, who would you hand over to? Because the systems are not existing to take up these services. I think for me, it also takes me back to, in terms of if you're thinking of formalizing this mobile health and nutrition outreach, I think the services are really, of course, they're very comprehensive and required. But what we're talking from a donor perspective, it's mainly donor funded. The Ministry of Health normally, they just second staff, and then it's mainly the donors who normally fund the services. So the best that the Ministry of Health can do is give you health workers who will also pay in terms of per diem and their service provision. So I think that is the limitation of this approach, because given that the government already is weak and also the areas underserved, I think that's one point that we should really advocate for, in terms of what is the presence of government in these areas and what is the investment plans, because you have to hand over to someone. Then also something worth considering, because we've also been pushing, particularly for South Sudan, given that we see that sustainability is an issue. We are also pushing towards this ICCM plus, where what kind of service provision can be provided at the community level with the capacity of the community health workers, and then what services can now be referred to health centers wherever they are. So I think that is something that is worth considering, particularly in contexts where the health system is really weak, that how do we empower the community in terms of, there are always community health workers everywhere. If they can treat the basic childhood illnesses, and also in terms of treatment of some and mom, and then refer the complicated case. I think that would really reduce the workload in terms of, or even the need for this mobile outreach, and can also help with the scaling down bit. Because if the community is empowered, they can take up some of these services and then refer the most complicated ones to the existing health facilities. That would really help in terms of scaling down and ensuring at least some continuity of services. Thank you.
Thank you, Suzanne. Some really interesting points there about coupling it with ICCM or ICCM Plus, and really using the mobile health services to move to the areas of the highest need for caseloads that are far from health facilities and cannot be dealt with in the community. And I think you also raised an interesting point there about who funds mobile health teams and whether that's actually part of the Ministry of Health's approach in a crisis when there's massive displacement or health facilities are damaged, because so far that's mostly a donor funded approach. So thanks for those points. I think Amal was next.
Yeah, I was just listening to the different discussions, and I do think I like the idea of using health facility staffs. Either it's the static staff or the staff from a health post or health center that has been destroyed, as in the case in South Sudan, because in that particular way, because some of the models I've seen is that they've been more health center staff that's go out, but that is then received per diem, and it demoralizes the local level staff, as higher level staff are then benefiting from the per diem, but they're basically going out there. But if it was a case of utilizing the health post, the destroyed health post staff, or the health post staff that is far from the affected population, to be able to go out. Obviously, there's going to have to be some rotation or some way of managing the staffing so that there's staff that remains in the health post. But that would then create a situation, and then after mixing that health post staff with a health center or higher level staff to be able to provide quality overseeing and supervision, would then provide that capacity building, on the job capacity building, high caseload, connection with the community, trusting with the community, and that would be a far better approach than bringing in teams that comes from outside of the local health facility or the local catchment area or the nearest catchment area if it's destroyed. And that might, and bringing in the whole system into, so in essence, moving the whole system that was at the health post level, so the nearest level, into the health facility without doing parallel. Because right now in Ethiopia, it's parallel reporting, it's parallel supply chain, it's parallel, which I understand why, because I was one of the first ones to be pushing for that, because but at the same time it's ongoing, and these parallel systems are just at the worst case scenario undermining the existing system, and best case scenario not strengthening them. I don't know if that's feasible or if that's a bad idea. I don't know. I'll stop there.
I think it's a very interesting idea. So having that close connection and using the staff, if I'm understanding what you're saying, who were at those static health facilities that are now inaccessible or destroyed. So using them as part of the mobile health and nutrition team, and then phasing them back into the health facilities as a scale down approach. Has anyone tried that before? Are there thoughts about, should this become one of our key recommendations or considerations?
Can I clarify?
Yes, please.
Just let me add, I mean, already Amal has explained a lot. In Ethiopia, the setting is two. Like in Somali region, the mobile health and nutrition service is owned by government because of the mobile nature of the population. Government seeks support from UNICEF, WHO, other INGOs, and it deploys, mobile health and nutrition teams permanently. I can say they follow the people, and it could be throughout the year. And in other locations like Amhara region of Ethiopia, when a conflict strikes, we deploy, mobile health and nutrition teams. And in most instances, we hire project-based teams that are recommended by the national guideline. And in rare cases like Tigray region, because as Amal mentioned, the health workers are there, the community displaced because the facilities are not functional there. So we try to just recall those health facility staff to reopen the facilities and provide the service through the mobile health and nutrition approach. So just to clarify, the whole idea is the same with the others. Thank you.
Okay, so just to make sure I got it correctly, so you are using the same health facility staff who would normally be at those health facilities. And I understand it's all ministry run, but there's no parallel structure. They're the ones who get put into the mobile health teams. Is that correct?
Yeah. Yes, we also bring, we also bring teams from outside, as you mentioned earlier, because
so it's a combination.
It's a combination, yeah.
Okay. Okay. I can speak to an example in Chad where basically it's not destroyed in Lake Chad region where it's not destroyed health facilities or inaccessible. It's just the lack of health facilities where there are very large populations. And there as well, it's the Ministry of Health who have provided some of the staff. It's a bit of a mixed team between INGO Ministry of Health staff. And interestingly, some of those sites where the caseloads never went down, like Regina was mentioning, actually the Ministry of Health decided that those could become permanent sites. And Concern has used containers to basically create a new health facility in that location, and then was able to move the mobile health team to a new location that had high needs. So Suzanne, please. I think you're muted, Suzanne.
Sorry, that was an old hand. Sorry about that. Let me just lower it down. Thank you.
A legacy hand, as they like to say, no problem. Any other thoughts? So we've talked a little bit about how to staff the health facilities. We've talked a little bit about the challenges of scaling down. How do you scale down and hand over? We only have a few minutes left before we go into plenary. Are there any thoughts maybe on any advantages or disadvantages of various models that you've tried, or any other kind of key considerations? We've talked a bit about budgeting, staffing, scale up, scale down, location. Any other thoughts before we
probably
go back into
one
plenary?
point?
Yes.
While we are planning to have this mobile health and nutrition team approach, I think it is better to include some activities like strengthening the existing health system in one or in another way, like provision of materials, provision of some equipment, including rehabilitation of the damaged health facilities, which might support the scaling down strategy a little bit. Because while implementing MHNTs, at the same time, if you are strengthening the existing health system, it will be much easier to pull out rather than just keeping only the lifetime of the project. Thank you.
So looking at the approach being not just switching to mobile services, but also in the background, trying to support those health facilities to get back up and running. I think that's an interesting approach and something that maybe we often forget because we get quite focused on responding. Jackie.
Perhaps as a nod to some of the other work we're doing on preparedness is perhaps to identify on the seasonal calendar, perhaps the times of the year where that additional capacity might be needed. All these complex situations are not chronic 365 days a year. You know, there are surges and peaks. So, you know, honing them down in the seasonal calendar and therefore being able to mobilize for short spans that are linked to previous analysis.
Thanks, Jackie. I think that's a really important point. And particularly, I imagine, obviously, the conflict in Ethiopia, that was a bit unpredictable. But for example, the flooding in South Sudan happens every year. And probably around the same time, though colleagues on the call could clarify for us. So being prepared for those moments and having that clear scale up and scale down plan and knowing where the staffing will come and the resources. Thanks for that, Jackie. I suppose that's in some ways very integrated into the CMAM surge approach, isn't it, as well? Or it could be as kind of one of the planned responses in the surge approach. Yeah. Any other thoughts? I think, I'm sorry, I'm just looking to my co-facilitators. I think we have 3 minutes before we go back into plenary. Any other thoughts? We'll go with Ruth.
Yeah,
if that's all right. Thank you.
Thanks. I've been sitting here just reflecting on the discussions, and you know, I can't help it but to look at South Sudan where I am, where there's, you know, it's an 11-year-old country with very poor infrastructure in terms of the health system. If we talk about community health, for example, the Boomer Health Initiative is only covering 33% of the population. So you're starting from a very poor baseline. With also a lot of the health and nutrition services actually provided by international organizations or supported by international organizations. So if you look at that, it's, you know, the mobile health services are not only addressing sort of the crisis, but also really addressing some of the, you know, the gaps in the system. And therefore, I quite agree with I think it's Ayanish who was saying that it's also for a country that is as young as South Sudan, I think also a focus on health system strengthening is very critical as we do the response through the mobile health and nutrition services. And that would include even, for example, making sure that at least the government can start paying its staff and not depending on the, you know, international partners to be able to provide just the basic services on that. And just from experience with for example, the RRM, the rapid response mechanism that kind of comes in during the, you know, also the crisis. I think, you know, we've been having a couple of situations where they've stayed for 2 years and the time is still ticking, you know, because there's just no one to hand over to. And it's because there's no infrastructure, there's no staff to do it. So I think that health system strengthening is very, very critical part of the strategy. Over.
Thank you, Ruth. Those are some really important points about mobile services in health context where there are a lot of gaps already, and the importance of the parallel health system strengthening and building up the resource of where to hand over to. Amal, I'm sorry, I think we're coming out of the breakout room in 15 seconds, but in the plenary, please do jump in if you have additional points when we feed back, if that's all right.